Bismillahirrahmanirrahim. Can you hear me?
Yes, sir.
Yes, sir.
Okay. First of all, I welcome all of you to the grand round today. We decided on the topic of dengue fever for a reason, and the reason is that there is a lot of diversity in treating these patients, and no current consensus among the clinicians as to when to start platelet transfusion or when to give fluids. And the most important of all is when to do the decision of admission in the hospital. And this we also encounter within our own hospital and our own practice, that some consultants would prefer the patient to go home and the others would think that he should be admitted. So the reason for today's talk is just to update ourselves regarding the guidelines, and we have based our talk on the WHO guidelines regarding the dengue fever outbreak. Emergency Department Registrar Dr. Sabeel, who has completed his FCPS training, he's going to present the slides, and I'll be around to answer any questions at the end. This is all based on the WHO guidelines. So over to you, Dr. Sabeel.
Thank you so much, sir. Thank you so much. Bismillahirrahmanirrahim. Hope I am audible to all of the listeners. As I explained, today's presentation is about the dengue and its consequences and regarding the decision about the admission and the treatment options. Let's start. Dengue is basically a viral illness that is most common in the tropics and the subtropic regions. And the mode of presentation is the febrile illness that can lead to the most fatal hemorrhagic disease. It's basically belong to the family of the flavivirus, that is an RNA virus, and some one along with the virus groups. There are basically the 4 serotypes that can infect the human beings, and the dengue serotype 1, 2, 3, and 4. Basically, in this disease, the humans are considered as an end host, and they are again considered as the feeder for the mosquitoes. So the infection with the one virus can give the immunity against only that serotype. If NS1 infect the patient can get immunity against the NS1 only, and the rest of the serotypes can be reinfect the patient with the more worst presentation. There is a vector that is the Aedes aegypti, that is a cause of the dengue fever. The risk factor is basically about the uncontrolled urbanizations or the most rainy weathers, the substandard housing, inadequate water and sewerage, and the waste management. It's also related to the deterioration of the public health infrastructure, faster travel, basically to the areas where the dengue is most endemic, like in Pakistan, and the ineffective mosquito control in the endemic regions, and the hyper-endemicity, that is basically the prevalence of the multiple serotypes who are going to infect the patients. How can a patient present to us? The patient presented to us, basically it's divided into the 3 stages, that is a febrile phase, critical phase, and the recovery phase. The most common presentation is the fever, that is basically an intermittent fever, low grade to the high grade, along with the rash, diarrhea, vomiting, muscle and joint pains, mouth and a nose bleed, headache, and sudden onset of the fever. The rash that is present in the dengue fever, it is maculopapular along with the Motting type rash that is during initial 2 to 4 days of the fever onset. Vomiting and diarrhea, they are considered as non-specific symptoms, but if the patient present with the fever along with the diarrhea and vomiting, then these are considered as the warning signs, and the patient is at the most risk for the development of critical phase and even for the risk of the dengue hemorrhagic fever. In a critical phase, it is just because of the pathogenesis that will lead to decrease the capillary permeability, and it lead to third space loss that cause the hypotension, and the same thing that is explained in my upcoming slides, that is basically called as a dengue shock syndrome or a dengue leak syndrome, that present with the pleural effusion, ascites, and gastrointestinal bleed. Recovery phase is with the altered level of the consciousness, seizures, itching, and the slow heart rate. Again, the slide that explains the dengue symptoms. The fever can present all of these presentations, that is like the eye pain, that is basically the retroorbital pain, and on palpation there is a tenderness in the orbit, muscle pain, bone pains, joint pains, rash, nausea, vomiting, that I already explained. It is basically the warning sign, headache, and the fever. WHO case definition of the dengue hemorrhagic fever. According to WHO, acute febrile illness with two or more of the following: the headache, retroorbital pain, myalgias, arthalgia, rash, hemorrhagic manifestation, leukopenia, and hepatomegaly. What is basically the pathogenesis behind the dengue hemorrhagic fever? It is all just because of the vascular permeability. The active complements that will lead to the increased vascular permeability that cause loss of the plasma from the vascular compartment and third space loss, and cause the hemoconcentration and the shock. Disorder of the homeostasis involve thrombocytopenia, vascular changes, and the coagulopathies like DIC, disseminated intravascular coagulopathy. The severe hemorrhagic shock, again, it can be present with the dengue shock syndrome or a dengue leak syndrome. Criteria for the diagnosis of dengue hemorrhagic fever: it occurs along with the deficits of the fever, swelling, along with all of the following that must be present in the patient's presentation: the fever, hemorrhagic tendencies, petechiae, ecchymosis or the purpura, bleeding from the other side in the positive tourniquet test, thrombocytopenia if the T platelet count is less than 100,000. Evidence of the plasma leak. This is very important, that will give us the guide regarding the patient's treatment with the IV fluids, the hematocrit, the hemoconcentration. That is basically the first and the most important sign of the dengue shock syndrome. The hematocrit, if it rise more than 20% or the hematocrit drop more than 20%, the patient is at risk for the dengue shock syndrome, and in that case we have to consider patient for the IV management. The pleural effusion, ascites, and the hypoproteinemia, it all just because of the vascular permeability and third space loss. Here's a presentation of the petechiae. Dengue shock syndrome, according to the criteria, all of the above that I explained in my previous slides, the hemorrhage, fever, thrombocytopenia, and the evidence of the plasma leak, along with the evidence of the circulatory failure, the rapid and a weak pulse and a narrow pulse pressure, cold clammy, skin restlessness, and often present with the abdominal pain, in which case mistaken for the acute abdominal emergencies. It is the grading of the dengue fever. The dengue virus is grade according to the WHO in a dengue hemorrhagic fever 1, 2, 3, and a 4. The same definition for the dengue fever is a fever of more than 2 with the headache, retroorbital pain, myalgia, and the arthalgias. And the lab investigation will reflect the changes like leukopenia, that is most common, thrombocytopenia, and maybe no evidence of the plasma leak. In grade 1, all of the above clinical findings, along with the positive tourniquet test, like there is a petechiae or ecchymosis and the platelet count are less than 100,000 and the hematocrit rise are more than 20%. In stage 2, along with the grade 1, with the spontaneous bleed due to the vascular permeability and the thrombocytopenia. Grade 3, along with 1 and 2, plus the circulatory failure, that is with the weak pulse, narrow pulse pressure, and again with the hematocrit rise of more than 20% or the drop of the more than 20%. The grade 4, profound shock with the undeductible BP and the pulse, that is again with the presentation of the narrow pulse pressure and weak pulses. The lab evidence is the same for all of these grades. The lab diagnosis that is most important to diagnose the patient along with the clinical presentation is high sensitivity test, that is basically an appeared sera of the fourfold rise or the fall, that's cross reactivity, IgG and the IgM levels. Basically IgM that is appears after 3 to 5 days of the fever or the infection, and the IgG level that appears after 9 to 10 days of the fever and the infection. And the viral isolation sensitivity is less than 50%, and the PCR that is the most standard, the gold standard and the most specific is in more than 90% sensitivity. The lab's criteria for the dengue infection, the probable cases and the confirmed cases. In a probable cases, circulatory failure with sportive serology, acute high titer that is more than 1,000 to 80, comparable IgG, ELISA, or the positive IgM. Unfortunately, we are not going to do our IgG and IgM or NS1 here, and along with the ELISA methods, we use the KIT method. Or occurrence at the same location and this time. So after confirmed cases, isolate the virus from the serum, autopsy specimen, demonstration of the dengue virus antigen in the serum, CSF or the autopsy tissue, detection of the dengue virus genome by the PCR. So there are some differential diagnoses that we can confuse with the patient of the dengue fever. Despite the infections, measles, rubella, that is basically German measles, malaria, meningoencephalitis, pyelonephritis, and septicemia. That is basically a very important task for physicians, how to manage the dengue, hemorrhagic fever or dengue fever simply, because there is no specific drug or no specific treatment. It's just all about the supportive treatment. Use the analgesic, basically antipyretics and anti-paracetamol, and avoid the use of agents which may impair the platelet functions like aspirin and NSAIDs. There is an algorithm that tells us how can we manage the patient with the dengue hemorrhagic fever. If the hematocrit is 20% of the above normal, then we can consider that patient for IV fluids, that is a ringal lactate or normal dextrose saline or a normal saline, at the rate of 6 to 7 ml per kg per hour. And during the infusion, we have to monitor patient's hematocrit, heart rate, pulse pressure in intake and output record. If patient improves and hematocrit drops back to the normal and BP rise, then we have to reduce our infusion rate to 3 ml per kg per hour, and further improvement, discontinue the IV fluids after 24 to the 48 hours. If hematocrit rise and pulse pressure falls and heart rate is rise, increase the infusion rate to more than 10 ml per kg per hour, and if no improvement, then 15 ml per kg per hour. Unstable vitals, CVP line, urinary catheterization, rapid fluid bolus, and hematocrit rise, then if hematocrit rise, consider the colites, and the hematocrit falls, then just maintain the output record and orally encourage the patient. There is an indications when we have to start the patient with the transfusion with the platelets. The prophylactic transfusions in a non-bleeding patients, if the platelet count is less than 20,000, only 20,000, if patient is not bleeding. In the therapeutic transfusion, if the patient is bleeding, significantly active bleed with a platelet count of less than 50,000. And along with this, there is a proven disseminated intravascular coagulation. What is the dose of the platelets? In the adults, it's 1 to 1.5 units of the platelet concentrate per 10 kg. And in a neonates, it's 1 unit of the platelet concentrate per 2.5 kg. How can we check the response to the platelet transfusion with clinical response and the platelet count increment? So here's a revised WHO criteria that gives us the clinical overview regarding the patient severity index. We classify the WHO's, according to WHO, dengue into the three stages. That is a probable dengue, warning sign, and severe. Or in another way, we can say that's the probable dengue is without the warning sign, patient with the warning sign, and a severe dengue fever. And probable dengue lives in or travel to the endemic areas. There is a fever along with more than two other presentations like nausea, vomiting, rash, aches and pains, tourniquet test positive, leukopenia, and any of the warning sign along like abdominal pain, tenderness, persistent vomiting, clinically fluid accumulation, lethargy, restlessness, liver enlargement that is more than 2 centimeters, laboratory increase in a hematocrit, concurrent with the rapid decrease in a platelet count. And one thing I'm really sorry not mentioned here, that is about basically the radiological findings in the warning sign. That is the gallbladder thickness along with the pericholecystic fluid accumulation. That is basically a warning sign, and these patients are more prone for the dengue hemorrhagic fever or the dengue shock syndrome. Severe dengue, severe plasma leak, shock, fluid accumulation with the respiratory distress, severe bleeding, severe organ involvement, hepatitis, ALT or EST are more than 1,000. That is basically a toxic injury, impaired consciousness, heart, or the other lung and other organ involvements. So all is about the prevention. How can we prevent the spread of the dengue? Avoid and the mosquito measures. Avoid the open stagnant water in and around the home. Use the bed nets, long sleeve cloths in the house, spraying repellents, and the pediatric dengue vaccination. Vaccination that is basically indicated in the pediatric group from 9 to 16 years, and it is only beneficial for those who are previously infected with the dengue, and it has an efficacy of more than 50%, but it can be low efficacious in young adults, those with the NS2 type serotype, and not previously infected with the dengue fever. One is a very high risk if vaccinated with the dengue vaccine who are not previously immune. In those cases, the dengue can be presented with the more worse presentation. Thank you so much. If you have any question, please, you're more than welcome.
Thank you very much, Sabeel, for a short and concise review of the dengue fever. It essentially answers all the questions which I mentioned at the start of the presentation. And just to recap them is that any patient presenting to the emergency department, we will do all the triage and we'll do the vital signs and send his routine bloods and see about the hematocrit. And if there is a rise and fall of the hematocrit more than 20%, so these are the patients who are at risk of hemorrhagic shock syndrome. And these patients would have to be admitted and would have to go on IV fluids. And depending on their response, the IV fluids either to be reduced or to be increased. As regards the patient platelet transfusion, non-bleeding patients, anything below 20,000, they would need platelet transfusion, and that is also to be weighed according to the weight and 1 to 1.5 units per 10 kilograms. As regards the bleeding patients who are bleeding, the count with a platelet count of less than 50 have to be transfused with platelets, and the response is seen with the clinical improvement. As regards the testing of the dengue fever. We are not doing an ELISA in our hospital. We can do PCR, but at the moment we are doing the antigen testing, NS1. I think that's in a nutshell the clarity I wanted for all of our clinicians and for ourselves as well in the emergency, so that all of us are on the same page as regards the patient's management. So thank you very much, Sabeel, once again, and we'll wait if there is any comment or any question. Thank you.
Thank you so much.
So I think there's no question. So thank you very much, everyone, for attending. And hopefully this will help us in improvement of our practice. Thank you very much, Sabeel.
Thank you so much, sir. Thank you so much.